Thank you very much for inviting me to talk today. I'd just like to say how the union certainly enacts out its kind of networks in interesting ways and is very open to bringing people on board. So Professor Don Ennison invited me to be involved in developing the qualitative research, both in terms of operational research, types of qualitative research, and as an associate editor in the journal. I'll tell you a little bit. I'm going to tell you a little bit about TB and some issues around TB control. We're going to look at the current WHO policy to implement that, and then I hope to showcase the importance of qualitative research to understanding some of the impacts and effects of this particular control policy. And we'll be hearing some research to come and some research that's gone in from South Africa and Shanghai as well. So just to move on, TB is a huge and remains a huge global health problem. There are estimated to be 8.7 million new cases of TB a year. 13% are co-infected with HIV. 1.4 million people still die from TB. And there's a rising multi-drug resistance problem as well, and we see the very specific socio-political context around MDR. So South Africa has a particular MDR, and indeed XDR, extensive drug-resistant TB, was first reported from South Africa, and the former Soviet Union, and so on. I'm not going to go into that into sort of epidemiological specificity of it. But access to TB care has expanded substantially. It's expanded substantially from about the mid-1990s. So with the introduction of the WHO DOTS, a directly observed therapy short course policy, and more recently with the Stop TB strategy from 2006, so that there are now substantial numbers of people who do have access to treatment and are successfully treated for the condition. This is the sign as you walk into the the National TB Centre in Kathmandu. DOTS is the answer. Now, it's a five-pronged strategy that involves a number of issues. It's very much focused on getting the diagnosis right and then getting the drugs to the people who have the diagnosis and making sure that they're taken. I'm not going to go into critiques. So we've already heard that TB is a disease of poverty, and there are sustained criticisms of this particular approach, but I'm going to leave those to other people. But it's about political commitment with increased sustained financing. That's one of the key issues. Case detection through quality assured bacteriology, which in fact was, until very recently, mainly the ability to using microscopy. That's changed in the last few years. I'm not going to talk about that with the rapid advent of new diagnostic technologies. Standardized treatment with supervision and patient support. This was the DOT component, a directly observed component. I'll be talking a bit more about that. An effective drug supply, and management systems, and then importantly, the ability to monitor and evaluate the impact of measurement. So the ability to say, if you're working in an area that you've found X number of cases and that you've managed to cure them, and so on. Now, this limited approach became noticed quite quickly, and it expanded into the Stop TB program, so which is still currently ongoing. This included continuing with DOTS expansion, but also addressing TB-HIV co-infection and the rise of drug resistance, the need to think a bit more about certain more vulnerable groups and so on. The importance of contributing to health systems. This was a very vertical program, and it was never going to work in and of itself outside of the other health systems. So how and in what ways is health system strengthening involved? Engaging all care providers and engaging communities and those who have TB through various empowerment programs. And finally, the recognition, particularly that operational research is very important and necessary as well. So that's basically it. And it's being implemented and rolled out in almost every country in the world. Now, I'm going to talk a little bit about, in the context of Nepal. Here, this is a country, population of about 28, 30 million or so, 44 or more new cases of TB, 44,000 new cases of open pulmonary smear positive TB per year. It's a significant public health problem. Now, the research that I was involved in was having worked in the program as a medic, and I came out and retrained in anthropology, was called a broadly ethnographic and qualitative. And I was interested in how the TB, the program itself, how it got translated into practice at local level. So this was doing ethnographic work, that is, participating with and observing in clinics, interviewing those who have the disease, talking to their family, the meanings that they attributed to it, the experiences that they had in this process as well. So it was broadly ethnographic. Now, initially for my PhD research, I spent a very long time doing this, so it's nearly a year and a half. But I can give you just a couple of examples that came out of this. Now, the TB program in Nepal was run out and through the public services, through the state structure. Now, in order for to record and report on this and to treat, they have very specific categories for treatment. So if you come in and you're ill, you get put into a particular category, and then you're put on treatment for that category. Now, a new smear positive patient, for example, is somebody who is a new TB patient who has which the bacillus has been seen in the sputum. But it also included, for that part of this, and this is a sort of the category here, included having been less than 1 month's treatment in the private sector. So this category included that. There were other categories. Now, what I found was that the staff were struggling to implement this, and with the result that about 25% of those who came into the state system didn't fit the current categories for the DOTS recording and reporting. And they didn't know what to do, so these people were kind of coming in, they're saying, I'm sorry, we can't enter you into the program, you don't kind of fit into it, and they were going back out into the private sector. Now, two issues came out from this. One was that there needed to be slightly more expansive way of so that they could be included in treatment possibilities. And two, it skews the way in which the DOTS program represents its success. Yes, it is representing the successes on the terms within which people are allowed, but many of these people who weren't getting in, who are going to be the MDR patients, for example, are not getting in and getting recorded into the system. So that's one example of why this sort of local research is important, the unintended effects of particular policies that are introduced. The second was the need to see the control of TB more from the perspective of the patients and their families and from the complex issues that they face. This might seem like common sense, but actually there's so much focus often on getting the programmatic aspects right that the people who are actually afflicted and affected with the disease can often be marginalised. Direct observation of therapy had to be to somebody who was responsible to the health service, and this meant that they had to be seen to be taking their tablets by somebody in the health service. The health posts, for example, were open between 10 and 2, and the impact on their lives was enormous. Loss of work, for example, and so on. And again, it was a problem because some people were not, they couldn't fit into these sort of observation, and they were sort of leaving the system. I'm not going to talk about drug markets, it's far too complicated, but I have done work with Professor Roger Jeffrey looking at that, and there are other issues around that aspect of it. Now, as we've already heard, it isn't just about getting the research right, and particularly when you're a qualitative researcher, because we have the added problem of having to struggle against whether or not what we do is real science or not, but that's a different debate. But I was invited by to be on the national program review, and in fact there's another one coming up very soon, it was chaired by the union, actually, they ran it. But they were very interested, they wanted a patient-centered approach to the review itself, so including the voices. So I'd done this research, it had been published in various journals in Nepal. There was work in the Lancet that had looked at the problem of direct observation of therapy, had been published. But getting it into practice and policy was the next step. So I was involved in facilitating this process, and we highlighted this, we talked to some patients, and then we wrote this as a recommendation. And then with colleagues at Leeds, so that it became policy. And it was simply about having more flexible support structures for those who are ill with the condition. But then again, there's a need for practice to change. Trainings, desk manuals, and so on and so forth, which colleagues at Leeds were also involved. So this whole process of moving it across is one that's complicated, and there are multiple actors and so on involved in that. So that's that. Now I just wanted to flag, Laura, who's talking next, is a PhD student on, I was fortunate enough to get a Wellcome Trust Senior Investigator Award for a program looking at understanding TB control. And this is working with colleagues in Nepal, and here we have from an organisation called HERD. They're very deeply embedded in networks of operational research and with the NTP and so on and so forth. The areas that it's looking at, again, issues around the implementation of the Stop TB strategy, a very broad and quite complicated question about how the Global Fund has stimulated civil society in the private sector. And Alice Street, who's here, and I will be doing and comparing that between Nepal and Papua New Guinea. How has it changed the approach to TB control? What are the issues at stake there? There's a question around the emergence of XDR-TB and the treatment of MDR-TB, which involves quite complicated legal, political issues and questions of incarceration. And Laura's going to be looking at that in context of South Africa. There are new diagnostic technologies, of which GeneXpert is the most recent, which are now being rolled out, which are changing the face of diagnosis of TB. But the sort of issues around how this impacts on broader laboratory and health systems performance is another question that we'll be looking at, comparing India and Nepal. And then finally, working with HIV, those living with HIV who are co-infected, what experiences do they face around accessing services, questions of stigma and so on and so forth. And key to this is feedback for the WHO and country policies, so sort of trying to embed it in that process. So, with no more ado, just 2 quick points. Social anthropology and qualitative research does, I think, importantly, 2 things. One, we can question the assumptions embedded in institutional framings of how to approach diseases and the effects of that. And secondly, it looks closely at the way in which policies are translated into practice, in particular cultural, political, social milieu. And I shall hand over to Laura at this point.